Thanks very much for that introduction, Phil. And it's really great to be here at this amazing conference. And good on you all for staying for the very last plenary of the whole 3 days. So thank you for doing that. And hopefully we'll have a little bit of a tour of a bit of a journey of some work that we've been focusing on. And I'm glad, Phil, you picked up the intonation issue, because it is meant to be exactly that. It's about time, and it's about time. So yes, let's try and talk through that. It's been an excellent 3 days here, and thank you so much for Psychosis Australia for putting this on. And really, it's been tremendous to have the breadth and spread of the talks that we've been hearing about. It's been great, and I've got some wonderful mentors in the room, including Phil and Stan and Marianne, who very much have guided me into a whole lot of my clinical and my research interests. But I've also got a whole lot of colleagues here as well that I'm really speaking on behalf of. So I shall move forward and share the story. Okay, so I don't know, for those of you who are Sydney-siders, you'll know the Sculpture by the Sea exhibition. For those of you who are not, I really do urge you. It's an annual, minus COVID, fantastic sculpture, and you'll see a sculpture festival, and it's on at the end of October, beginning of November. So do urge you to come to that. And I really am going to be sharing my view, but the work of my team and our work over the last 20 plus years, and really with this focus on this plenary around making change and how we look to the vision for the future. So here we go. If I can move that forward. There we go. So I think this is something that everybody knows about now, but perhaps not the case when we started this work 2 decades ago. So the fact that there's a 15 to 20 year life expectancy gap from people who live with psychotic illnesses compared with those who don't has been variously called lethal discrimination, the scandal of premature mortality. Absolutely clearly known now. Wasn't the case when we started this work, but there's plenty of documentation, and it's been mentioned many times during this conference as well. But I want to give you a different take on it, just to give it a bit more of a context. Here's a photo of a family taken in Europe just before World War II, and there's 3 children there and their parents. All 3 children married in their 20s. All 3 had a son and a daughter. All 3 had significant cardiovascular disease, as a premature cardiovascular disease, as did their father. 2 of the siblings lived into their 80s with very good medical care and surgical care. One of them developed schizophrenia in their late 20s and died at the age of 62. That's the impact of premature mortality. More on that later, and more on the family later. I've only got 2 slides with any numbers in it, so I'm just trying to keep you awake for this time of day. This is one of them. This is really saying that the accumulation of the cardiovascular risk factors happen really early. So by the time you come into our services, the first episode psychosis services, you've already doubled your risk of having metabolic syndrome, the constellation of symptoms and features that make you at high risk of dying prematurely. But by the time you end up in the more enduring end of psychotic illnesses, and perhaps are on clozapine, the risk of you having metabolic syndrome, or the prevalence of it, is much higher, 50 to 60%. That's the usual course of this physical health comorbidities, as well as tobacco and the huge impact that has on people's health as well, and driving towards premature death and morbidity. But does this have to be your destiny? Is this necessary as a pathway for anybody who's being prescribed antipsychotic medications and so on? I think that's probably how we looked at it in the past. And just again, it was a sort of, no, you can't do anything about this. But there was lots of gaps, missing pieces to the evidence. We really didn't know what to do about this. We just knew that there was a big problem. So that was how it was 20 years ago. Over these years, and this is just a snapshot of what's happened to the growth in the landscape, there's been an absolute abundance of clinical interventions, clinical evidence, meta-analytic evidence. There's been a Lancet Commission on the physical health of people living with mental health conditions, and huge number of, well, significant numbers of guidelines, state, national, and beyond. And really, there's a lot that we now know, but there's still a problem of actually translating that. Our own team, and we'll just share a tiny bit of story about that. It started off as a clinical program, the Keeping the Body in Mind program, and then really developed a body of work and a suite of resources, some of which I'm going to share today. And then it moved across in the more recent years to the Keeping the Body in Mind Gardens as an extension, which is a translational research arm of the original clinical service. And this is just a snapshot of some of the work that we've done, just to give it a pictorial representation that this has been a journey over 20 years. It really did, though, start with a simple observation, a clinical observation, that young people who were coming into the first episode psychosis service where I worked at the Bondi Centre really were just putting on weight in front of our eyes, but we had no mechanism to actually determine how to measure or monitor. There was no protocols in place. So we set about developing a clinical tool, and it had various incarnations, and eventually now it's in the electronic medical record system. But back then we just literally thought, well, let's measure and see, is there a problem for young people with who are coming in with experiencing first episode psychosis. Then it was, okay, yep, there's a problem. What do we do? So I went about looking around the literature. Is there any evidence? Or what should we do about it? I found that in that situation, where it's collective, we looked up some literature, there really wasn't evidence to help us to understand what to do in terms of implementing some solutions to this issue. And I think that's a really important piece. We heard from Alison as a question to Brian Burdikin on the first day, is it a human rights abuse to not provide evidence-based interventions for people living with mental health conditions? And yes, that we do need to provide that. But if there's absence of evidence, do we do nothing? And I think this is where our journey happened in a different sort of way, because we actually had no evidence in those days of what really worked. And I'm talking when we started, the metabolic monitoring form was 2004 and 5. So we had to sort of develop something to do, because we couldn't just watch and wait and do nothing. So then was more thinking and talking at that stage to a whole lot of colleagues. What should we do? How should we do it? And I must say, this was the prevailing attitude at that time. We're psychiatrists and mental health professionals. We just deal with everything above the head. Forget the body. That's GP land or someone else, certainly not ours. And then if it was, no, we really want to, they were just, oh no, it's too hard. It's already hard enough to deal with psychosis and all the mental health sort of and psychosocial issues. Forget about the physical health bit. Don't even try. We persisted nevertheless. Through a small grant for registrar training in 2010, we developed at that stage, alongside of Hannah Newell, who was our med student at the time, and now Hannah Miles, a psychiatrist in Adelaide, and Catherine Samaras, who's a professor of endocrinology at the Garvan Institute and St Vincent's Hospital in Sydney. We developed a clinical tool for clinicians about how to actually try and intervene for people on antipsychotic medications who otherwise may not be getting the care that they needed, because people didn't really know what to do. So we really invented this as a clinical tool to train registrars initially, and then it has gone on to a whole lot of other have a whole lot of other impacts, and I'll share that in a moment. But really, that's all we did in the beginning. Looked at what the evidence is for people without psychosis and actually adapted that into, well, how could we make sense of this so that the medical clinicians could know what to do. The GPs took this on, and then it had its life of its own at that point. We were thinking a lot about the physical health, the sort of biological markers, blood pressure, lipids, and blood sugars and so on. But at the same time, we were working with young people who were putting on 10, 20, 30 kilograms in front of our eyes in a short period of time. And what they were saying was they weren't interested in whether they were going to die young of cardiovascular disease. They were interested in, they couldn't fit in their clothes. They actually didn't recognize themselves. Their social life had changed. They were dealing with their psychotic illness, but the double whammy of this physical health and obesity that they they just really said they couldn't recognize themselves in the mirror or who they are anymore. So that was a really important piece as well, and more about that later. This is the Bondi Centre, where many of you who are here have worked and still work, some of us, and this is the origins of where the Keeping the Body in Mind program came from. And the original group room that we had there which was a patient group room where we had some sort of psychological interventions, had been transformed, and this is 2010 already, into basically a gym, purpose-built, non-purpose-built. I mean, it's a heritage house, which is not meant to have the gym inside it, but it certainly has, and it's the centerpiece of that service now. It was the first time we'd done that, and since then there's been lots of people who've replicated that, and I'll share how that looked. So it's got even purpose-built floors now. It's been it's tiny, but it is very much why young people come into our service, not because of the mental health elements. So the holistic care is really important. Now, another thing happened at that time. So the 2010 was the clinical algorithm to the registrars. We then got the gym the room transformed into a gym in 2010 as well. So in 2011, we had the opportunity to bring together, through a range of organisations, and I note a range there that I was looking at yesterday, including the Schizophrenia Fellowship, as it was known then, of New South Wales, who contributed to this, and RAFME as well. We developed a small workshop symposium for half a day. We brought out a wonderful colleague who's remained a colleague since then, David Shires, who I'll speak about in a moment, but we developed really an international working group called IFIS, with the symbols down the bottom there. And David and I were able to fund David to come out from the UK and really work together on pulling together what the evidence was at that time in 2011. It was interesting to go back through the program. There was just what we knew at that point in time. Really an important piece here is, and I want to actually pay tribute to Stephanie Webster, also known as Stephanie Hewitt, who some of you will have known who are in the audience, who very sadly passed away a couple of months ago. Stephanie was one of the strongest voices in changing the way that I thought about what we needed to do. Stephanie rang me ahead of this, saw the program, said, where's the lived experience voice here? I said, you're right, it's not here. It wasn't something that was so common back then. And she just, without seeing her, she just talked to me and she said, I want to speak. I said, okay, come and speak. And she was absolutely central to the whole movement of understanding what it was like from a consumer's perspective to go through and experience bipolar disorder, and then put on 60 kilograms, and what didn't happen with her care. So she was instrumental over the years, and we're very sad. She worked with us through this whole period. And just want to make a real dedication to Stephanie today for her contribution. Here's the only other data slide. We ended up a couple of years later actually getting some funds from New South Wales Health, and then developing an intervention program which we called the Keeping the Body in Mind program. It was a 12-week lifestyle intervention program. Several of the original people are in this room today, including Scott Teasdale and Andrew Watkins, and we had other colleagues at that time working with us as well. But we basically were able to demonstrate through a 12-week lifestyle intervention program of diet and exercise in young people with first episode psychosis that we were able to prevent antipsychotic induced weight gain, which was an astonishing finding even to us. We were then, we compared it to another early psychosis service in Sydney, which didn't have the same lifestyle intervention. And those young people, 75% of them put on clinically significant weight in 12 weeks, compared to 13% of those in the Bondi Centre. So we thought that was, quite extraordinary, and we actually, thought, well, okay, well, maybe that was a fluke. We were able to then replicate this, and that was the first time internationally that it was shown that you could do this lifestyle intervention to prevent antipsychotic induced weight gain. What that then led to was a whole program of work, and this is just a snapshot to share that as a result of the evidence. So I'm coming from a clinical angle, got some funding to do an evaluation and research on it, but really it was the advocacy and having the service and the service director at that stage, David Pearce, another visionary leader who really just saw what we were doing as something that he thought was really valuable and wanted to recurrently fund. So Even though we had 1 year's funding initially, he saw as a service manager the benefits to early intervention in this way and funded 4 teams, which still exist today across our local health district, each with a clinical nurse consultant, an exercise physiologist, a dietitian and a peer worker. We're currently funded in the core service. We then led on to a whole lot of other, we moved away from just first episode psychosis young people and to adults as well in the service and community patients. And we've moved to other areas as well, smoking cessation, sleep apnea, microbiome, etc. So we've really done a lot of work, and this is just a sort of description of that. This is the last infographic before COVID, so it's out of date, but we haven't repeated it because of the COVID sort of disruption to the numbers. But what it created was a whole program of work, a lot of students coming along doing their student placements at all levels, undergraduates, higher degrees, and publications, education sessions, and so on. It just created a momentum around this topic, which was local, but it was really terrific. Okay, a small breath, and to talk about Mindgardens. Now, Mindgardens is very proud to be a sponsor of the Psychosis Australia, this Australian Psychosis Conference. So, you know, that's a great privilege to be able to do that. Just highlighting, if you want to know more about Mindgardens, and we'd really like to connect with you, on your tables, there's a little card which has got a code at the back of it. You can enter into a competition to win out of the draw just by doing a short survey. We're really interested to know what people want from us and how we can be helpful to the community and at large. Basically, Mindgardens brings together the strength of these 4 pretty amazing organisations and really acts as a catalyst to change the way mental health, drug and alcohol, and neurological conditions are designed and delivered by bringing together people with lived experience, researchers, clinicians, health service managers, and community in an integrated manner to focus on outcomes, co-designing new models of care, and real system change. We do that through translational research, but it's really bringing the groups together. That's the key. There's a whole lot more information outside, as well as our website on these cards, so do feel free to hear more about us through that method. So here's some I guess one of our aims is to integrate, collaborate, and innovate. And I'm going to share later why I'm going to add, after this conference, advocate. So we'll come back to that. But here's our 3 main flagships, and you'll note that the psychosis flagship is one of our key areas of focus at the moment. There's 2 strong areas of our psychosis flagship already in existence, plus a plan to build a lot further with that. We've got the tertiary referral service for psychosis, which Kimberly Davis presented on yesterday, and some of the TRSP team are here today. There's also a brochure of referrals out on the desk, but basically it's a statewide service for people who are receiving case managed care across New South Wales to receive a complex care assessment and interventions as well across a 6-month period. It's really been it's in its 3rd year now, and it's going really well. And we've received funding from New South Wales Health, which is a real testament to the whole program and the need for psychosis care. The other big program inside of the psychosis flagship is the Keeping the Body in Mindgardens program, which I'll talk to you about in a moment. But again, that the leveraged ability for the Keeping the Body in Mind clinical program to move into the translational research was really obvious and a major feature of Mindgardens. Here are some of the Keeping the Body in Mindgardens team. And if you want to talk to any of them, we've got here today, we've got Rach Morell, who's over there, Andrew Watkins, we've got Eliza Draper and Scott Teasdale, who are all here. So please do feel free to talk to them. And this is just the KBIM Gardens team, but we've got other Mindgardens people as well. And just to show you what we've been able to do through adding translational research and our partner organisations to the mix, we've just built further and further opportunities beyond the initial clinical care for people experiencing psychosis who are receiving care from South Eastern Sydney Local Health District. So the expanded program, again, not going to go into detail, although a website's got videos and a bit of an explanation of some of these programs, but just some new targets and areas that we're raising expectations around. One is vaccine inequity. This is a huge body of work that we're doing, led by Patrick Gould. and really just highlighting the fact that people living with psychotic illnesses don't get the same level of vaccination, not because they don't want to be vaccinated, but because they're not given the opportunity to be vaccinated. So this is a targeted program that's been co-designed to actually change that. There's also ADDI Moves, which is a program that has extended the Keeping the Body in Mind principles to refugee and asylum seeker backgrounds, which is based in Marrickville, and then the primary care service, which is located at University of New South Wales, which is really about those people who are not accessing care from the local health districts and can't get the Keeping the Body in Mind program. This can be, if your GP refers you to the UNSW lifestyle clinic, you can get the same sort of care. At the moment, it's got a dietitian and an exercise physiologist. We're looking to add to that too. And that's supported by the Primary Health Network. So we've got multiple areas of influence and for our translational research hub in this regard. The research is really important, as is linking with the clinicians to develop some of that research. But the education and training is just as important to this, as well as policy and service provision. There's a multitude of things that we're involved in, as well as co-production. So it's a whole, as I say, body of work. It's not just about doing a clinical research project and then publishing the results. So the other ways that translational research hub has influenced is through these guidelines, or some guidelines. So these are some examples. The New South Wales physical healthcare guidelines, we were able to be involved in the development of those, and it's too small to see, but we've got our "Don't Just Screen, Intervene" motto that's inside those guidelines, and a whole lot of our resources are also linked to this. So this has been terrific to be able to contribute to that, as well as Your Experience of Service, which many of you will be familiar with, but that's the consumer survey that gets filled out for every person receiving care across New South Wales, across Australia, but the New South Wales version has got the physical health additions as well in there. We've also developed guidelines, for example, for exercise physiologists on how to work inside of mental health services, because we now employ more mental health exercise physiologists than any other. Like, our hospital has more exercise physiologists in mental health than they do in cardiology or respiratory and rehab. That's saying something. So we're actually trying to educate and train the workforce of exercise physiologists. There's also a guide in there for those of you who are psychiatrists on how to promote physical activity and physical activity for psychiatrists. So a step-by-step how-to guide. So these are the sorts of practical tools we're thinking about. Equally Well has been mentioned a few times, including by Rosemary Calder today, and we've been part of that initiative, and many of the people in our team are ambassadors for Equally Well. So back to the Don't Just Screen, Intervene clinical tool that we developed many years ago. This is now what's happened to it. It has a life of its own. It's been translated into 9 different countries, and really has had an influence by people coming to us, asking us if they can translate it and utilise it. Also, we've now moved to the international front and the influences of this initial clinical work. We've developed an international consensus statement called the HEAL Declaration, Healthy Active Lives, where we're really trying to raise the bar and ensure that young people who experience psychosis have the same life expectancy and expectations of life as their peers who have not experienced psychosis. In that particular declaration, there was a whole lot of, this was launched in 2013 now in the UK and here at the same time, and there were a whole lot of things that we put in there as aspirational goals that did not have evidence. But I can say now that since this has been put out, we've collected some evidence and been working through them. So we now can say that you can maintain someone's glucose and weight at 75% of people who are on antipsychotics can expect to not put on weight and not develop diabetes and so on. So we now, even though they were aspirational and there was no evidence to say those things then, we can say that now. And again, the HEAL Declaration has been translated multiply. And finally, on the international front, the WHO got onto this a little bit later than everybody else, but nevertheless, David Shires and myself were able to be involved in the writing of the guidelines for WHO on this topic as well. So it's gone a long way since the beginning. We also are very proud of being able to have developed a whole lot of consumer resources, all available on our website as well, and to raise expectations so consumers can go to, and their families can go to their health care providers to say, hang on, I need this. Where is it? Why am I not getting my cholesterol checked or whatever else. Okay, and just as an exciting introduction, we launched a couple of months ago at the Equally Well conference our new resource package, all of which is outside, or nearly all of which is outside. So you can pick that up. There's a QR code as well, but you can, it's also on our website, but we've co-designed and updated and digitalized all of our initial cardiometabolic health resources. So we have now got the 2023 version. This was funded by the New South Wales Mental Health Commission, and we've got an adult version, which is there. It really is a how-to guide. It is developed for clinicians, so and for GPs as well as mental health clinicians. Evidence-based to date, and Don't Just Screen, Intervene is still there. Front and back of it explains what you need to do, how often to screen, and recommendations and so on, and how to prescribe medications such as metformin and so on. There's the adolescent version. And we're also very proud to launch newly the tobacco treatment resource, which is also for people who have been prescribed psychotropic medications, acknowledging that there's a slight difference in the way that you do treatments and NRT and other treatments for people living with psychosis. And that's what that's been developed for, all out the front on the desk. We've also got video training resources for clinicians, newly launched. This was all literally launched a couple of months ago, as well as 17 consumer modules, which can be done. So this is recognising that not all services have exercise physiologists or dietitians and so on. And this can be done by the caseworker, NGO, or anybody else. Family carer could work through the modules with the consumer. And there's also oral health resources. And finally, the UK Leicester adaptation of our original work has been launched at the same time, almost the same day as our one. And the colleges of psychiatrists and GPs and Public Health England and NHS England have all endorsed the UK version. That's had more traction than the Australian version. We're hoping now that we've finished and finalised the updated version, we're going to go down that same pathway and try to do an implementation that involves all our colleges and so on. So anyone wanting to get involved in that, please come and join us. Okay, back to the family. Let's see if I can get the pointer working. Over here, that's Judy. That's my auntie. Judy, as I said, died at the age of 62. She did not receive care. It wasn't even thought through that physical health was important. And the impact of that, because she was living in Canada, this was some time ago now. But what she missed out on was seeing her grandchildren. She never got to meet them. Whereas my mother and my uncle did. They did have significant illnesses, my mother and my uncle, but they got to live the life that you would expect if you had good medical care, preventative care, and so on. That's the impact of premature mortality. What can we do about that? I think changing the future is really important. It's about time. It's about premature mortality gap. It's about the translational research gap, which is what this is about. It takes 17 years on average for a publication to reach clinical care. We've got to close both those gaps. And we cannot lose the translational importance here. I've given you what the past has looked like. I think we're on a new trajectory forward. I think there's a mixture of things. And my final slide. This is a not very clear, that's okay, model that I'd love some support on and co-designing on. It's just thinking through what the keys, we've talked about bench to bedside and back again. I agree with that, but I think there's the advocacy piece, and Sue touched on that earlier in her talk as well. We need to be doing translation. We need to have key stakeholders involved. We need to be lobbying governments. We need to be getting community partnerships, fundraising. We need to influence guidelines and policy in all ways we can, but we need to do that together. Conferences like this are really important for that. We, of course, need the clinical people on board and engaged with us, and we need to be implementing any evidence-based guides that are out there. We do need to do that. So we've now got the evidence, Alison, which is really good for us to be able to move forward. But we need to have the fundamental research and look at novel therapeutics. I'm glad that lithium's got a look in as being potentially good for everything. Metformin's the other one that I think we should put in the water as well. It's got lots of benefits. We've got to work together. We've got to bring those groups together, the clinical and the bench. What's inside there is knowledge translation and implementation science and reducing the gap. We've got to do all of that with the consumers and carers and their families in the centre of it, involved in every bit of those sectors and helping us draw together. We need to work on workforce. We need to expand the workforces. And really, this is a job for all of us, no matter which area we're in. So, oh yes, we can do it. I just like the cherry on top as a, I like that sculpture, so I can't really think of exactly way to frame it other than that. And real huge thanks to enormous number of people, many of whom, but not all of whom are on here. It's a team effort. We can all move forward together. And thank you very much. It's a work in progress. Thanks very much for listening.